Good morning, good afternoon, good evening, wherever you are, and welcome to this TechNet webinar session on the big catch-up monitoring in Mozambique. We're very happy and pleased to see you. You can already introduce yourselves in the chat. We'd be happy to know who's with us. In the meantime, let me tell you a bit more on this session. So you can listen to this webinar in French, English, and Portuguese. To do so, please click on the globe icon, which is at the bottom of your screen, and select the language in which you'd like to listen to this session. And now let me say it in French for our francophone audience. Bonjour et bienvenue, vous pouvez écouter cette session en français, en anglais et en portugais. Pour ce faire, cliquez sur l'icône en forme de globe en bas de votre écran et sélectionnez la langue dans laquelle vous souhaitez écouter cette session. Unfortunately, I cannot say it in Portuguese, so I hope our Portuguese colleagues understood, at least in English, where to find the interpretation, or are already used to it thanks to other sessions. So, as I said, please introduce yourselves in the chat box and tell us your name, maybe, and where you're from. And you can also use this chat box if you need any technical support. I'll do my best to help you during this session. If you have any question during the presentation or any question about the presentation, please use the Q&A box. It's available at the bottom of your Zoom window. Ask your questions at any time, and our panelists will answer them after the session during the Q&A session. Finally, this session is recorded, and we'll share with you the links to the video as well as the slides by email. Maybe one last comment for my colleagues who are going to present. Please do not speak too fast, as we have interpretation, and that would give a little bit of time for our interpreters to do an excellent job, and I'm sure that it's going to be fine. So I hope you'll enjoy this session, and I'll give the floor to Sarah. Sarah, the floor is yours.
Great, thank you. Thank you, Alex, and thank you, everybody. Good afternoon, and thank you for joining us for this yet another session of our deep dive sessions on the big catch-up efforts that are happening in our sub-region for East and Southern Africa. Today, we're going to be featuring Mozambique, who have so far conducted three outreach, well, how do you call it? 3 specific activities for big catch-up so far. And so they'll be updating us on what they have achieved so far, what their lessons are, and what they plan to do going forward. But before we hear from our Mozambique team, we will also hear from our HQ colleagues who will walk us through some big picture items on big catch-up monitoring within the context of catching up on our and under-vaccinated children in the sub-region. After that session, then we will welcome to hear from you, other countries, other regional colleagues and HQ colleagues on some of the learnings that we could also benefit from hearing about. And then we will do a recap of the recommendations and maybe some next steps. And then we will also be sharing a survey at the end of this session so that we can hear your thoughts on what your perspectives are on the ongoing big catch-up efforts in our region. So without further ado, I'm going to hand it over to Carolina, who can walk us through the big catch-up monitoring guidance that has been provided so far, as well as some of the progress that we are learning from the recent WHO UNICEF estimates on immunization coverage. Over to you, Carolina.
Thank you, Sarah. Good morning, good afternoon, good evening, everyone. I am Dr. Carolina Danovaro. I'm a medical epidemiologist with the Global Immunization Monitoring Team. And as such, I'm part of the team that does the WHO UNICEF estimates of national immunization coverage, WINIC, and also the team that developed guidance for monitoring catch-up in the context of this initiative that is the big catch-up. I will start by describing a little bit of where we are in the world in terms of coverage. So in this slide, to orient you, you have in the lines the estimated coverage for DTP1 and DTP3 in the African region. And you can see that DTP1 is at 83% for the year 2023, whereas the TP3 has a big dropout, it's at 74%. And then you have the estimated number of under-vaccinated children. You will see that compared to the year 2019, which is pre-pandemic, and also the baseline for the Immunization Agenda 2030, we are unfortunately going in the wrong direction, in the sense that there is more children who have not received any dose of any diphtheria, tetanus, pertussis containing vaccine, and dropout has also been remained higher. That's why it's one of the big reasons that this initiative of the Big Catch Up started, to try to cover these immunity gaps that have been left during and after the pandemic. Next slide, please. You will also see that as I mentioned in the other slide, that instead of going down in the number of zero-dose children, defined as those that have not received any diphtheria, tetanus, pertussis containing vaccine, we're going upwards. So to orient you to this slide, you have the estimated number of zero-dose children, and then in the African region, and then in the light blue bar on the right side, you have what would be the goal if we were to meet the Immunization Agenda 2030 goal of reducing the number of zero-dose children by half. You see that we would have to be following that line, that diagonal line, but unfortunately things are going the wrong direction. And this is just, as I mentioned, the number of zero-dose children, because dropout is still high. So this accumulation of zero-dose children and under-vaccinated children, of course, increases the risk of vaccine-preventable diseases. And the Big Catch Up, it's an initiative to respond to this. Next slide. One more click. So to orient you, in the year 2021, the year that really coverage was low in most of the world comparatively, Mozambique, you would see that ranked number 12 in the number of zero-dose children at that time. I would say it's a good thing for Mozambique that compared to 2023, the number of zero-dose children has been reduced. Therefore, it did not make it to the top 20 anymore. This slide, just to orient you, has the top 20 countries with numbers of zero-dose children. So some of them, the coverage is not that bad. For example, India coverage is reasonably good, but because it has such a large cohort, it makes it into this list. And then you see on the right-hand side, the list of top 20 countries with the most zero-dose children in 2023. Again, Mozambique had made the list of the top 20 countries with the most zero-dose children in 2021, but it has been reducing, so they left this list. Next slide. So I hope you remember that the Big Catch Up has three big components to it. One is catching up the missed cohorts in the last few years. The second one, it's going back to at least levels of coverage and in infants as seen in 2019, so before the pandemic. And thirdly, to strengthen routine immunization, including strengthening the routine and catching up of children. Of course, it's better to vaccinate people at the right age so they are protected from early on. However, it's better to vaccinate late than never. You will find on TechNet this guidance document. It's also available in Portuguese. The Portuguese version has not been reviewed by any native speaking Portuguese person. So please, if you're reading it in Portuguese, we would be happy to receive your feedback. But basically, this guidance includes information on the types of ways that you do catch up. So the catch up delivery modalities. Very importantly, how we know if a child is eligible for catch up. And there is some guidance on how you do that for children with CARs, which is easier because you would have the list of vaccines that have been received and missing. as opposed to when the child doesn't have a card, and some sorts of questions that you can ask to try to ascertain eligibility. Then, once you decide that the child needs an extra dose because it's missing something, you after you administer the dose, it gives you an information on how it's ideally you would record and report these doses, so that we can better monitor how these children are being caught up. Then includes guidance on how to monitor and evaluate the catch-up efforts, and includes indicators. This is really important because Gavi, for the countries that are receiving Gavi support to conduct big catch-up activities, is using the indicators included in this guidance for the requirements for reporting vaccination in the context of the big catch-up. And I'll get to that. Next slide, please. So I would say there are 3 parts to it. One part, it's readiness. It's an evaluation of how the countries are ready to start the big catch-up activities. So it includes checklist for indicators to make sure that, for example, policies are in place, that, for example, the doses have been received and everything is ready for them. Includes guidance on looking at the policies, etc., and the adaptation of the information systems. So because for monitoring, we need to make sure that the information systems have been adapted, it's really important that the tally sheets and the monthly reporting and the information system, the electronic system, it's also adapted. And also that the healthcare workers that are going to be administering vaccines to children that in other years may have not been eligible because of their age, now are ready to understand how to record them where and how to aggregate up for reporting them separately from the routine vaccination of children, usually infants, or in some countries, second year of life for certain vaccine doses like MCV2, measles-containing vaccine second dose. Importantly, the guidance include quite a bit of examples and tools that are adapted there, so that as you start the catch-up activities, you can go to the field and explore how things are going. Includes guidance on conducting rapid assessments. There is an example of conducting rapid convenience assessment or rapid convenience monitoring paired with the behavioral and social drivers. So you have a sense if people are receiving the vaccines properly, and if not, why not? And also includes guidance on how you do some quality checks, and also how you can go to the health facilities and adapt some tools so that you also understand what are the barriers to properly ascertaining eligibility and properly vaccinating the children who need it. And finally, once you have implemented the catch-up activities, and I think that's where we are at with some of the countries, it's to conduct case studies and adapt some sort of survey or other field assessment to better understand how it went and what can be learned, so that when normal catch-up of children that for whatever reason miss vaccines when they are young, when the vaccines is due, can be brought up to date and really rescued. I come from Latin America, and in Latin America we used to call caught up children the rescued children, because we rescued them from being zero dose and under vaccinated, even if it was a bit late. Next slide. So where we are at right now, we are in some countries, it's still in the planning phase. Other countries have started doing big catch-up activities, usually through intensification of routine immunization. And that's the moment to do the rapid convenience monitoring or rapid convenience assessment or lot quality assurance sampling or a post-campaign coverage survey, something to understand how things are going. And of course, looking at the monitoring, at the supervisions data and at the administrative data that should be now separated by age. And then, of course, all these assessments of how things are going should be done in parallel with the behavioral and social drivers, or questions about the barriers and enablers to receiving vaccines which might be different for children who are a bit older, and also to understand from the provision of services what might be the barriers for nurses or other personnel to vaccinate children who may be a little older than normal. And then at the end, it's important to do case studies. So we understand how did it go, how it went, and what can we learn so that we integrate what we have learned into routine, into conducting catch-up activities as a normal part of strengthening vaccination. Next slide. Then, as I mentioned, Gavi took this guidance that was put together by the Immunization Agenda 2030 Working Group on data strengthening and use. It's a group that includes many partners, WHO, UNICEF, JSI, PATH, CDC, Gavi, Gates, etc., etc., and took this guidance and developed a request for countries to report and to report on readiness. As I mentioned, how are the countries ready? For example, do they have the schedule? Do they have a standard operating procedures? Have they adapted the recording and reporting tools? Have they created some plans to ensure that people know where to go, what to expect? And also if they had done the capacity buildings to ensure that health workers are ready to deliver vaccination, catch-up vaccination, ascertain eligibility, and then vaccinate and then record properly. And then finally, then it comes the results and some indicators of how things are going. What is the implementation status of the different intensification activities, it's periodic intensification of routine immunization, or if countries have done supplementary immunization activities, campaigns, and how the children are being vaccinated, how many children have been vaccinated with the doses that are being used for catch-up, and by the different age cohorts. It also includes monitoring the number of vaccinated children at the correct age, so that we see if the catch-up activities are having an impact, be positive, ideally, on making sure that more children get vaccinated, or maybe negative. Maybe it's being detrimental to routine. So we hope it's positive, but that's why it's important to monitor the number of children vaccinated with these catch-up doses at the different ages. Next slide. Then, as I mentioned, during the activities, what assessments countries are doing to understand how things are going. Again, this is really important to course correct. If something is not working, by asking people what's happening in households and also in the health facilities, we can course correct. And this reporting form to Gavi includes questions about the assessments that countries are doing, including behavioral and social drivers, as I said, to understand the qualitative barriers and enablers to doing catch-up activities. And also so that the countries adapt their strategies to continue. Next slide. And finally, this reporting submission to Gavi, the deadline to include in the first reporting, which is today, it would include all the vaccinations ideally given up till now, but of course, being some delays might exist. So each region is taking consideration of this, and each region is creating, or sub-region is creating, a tool to facilitate this reporting. Again, you will find all the information of the guidance. It's available in Portuguese, as I said, French, English, and Arabic. And then it includes and you can also find information about the submitting this monitoring form to Gavi. WHO and partners are ready to provide technical assistance. And please, 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 if you have questions, if you need help, reach out to your WHO UNICEF country team. Thank you. And I think I have one more, maybe. Yes, the case study. So after the activities are implemented, it's really important that we understand what happened. And countries are invited to commission case studies to understand what went well and what could have been improved, and also how to take these lessons to inform catch-up activities. The approach is to do mixed methods, so quantitative and qualitative, and the protocol and sample tools are now available. And as I said, if you are interested, your country is interested, there is the email from my colleague to send us a request. But of course, you can also go through your country office and regional office. Next one. And this is all from me. Thank you so much.
Great. Thank you very much, Carolina, for that initial overview on how we're doing with big catch-up activities in our region, and really encouraging to see the upward trend, especially for Mozambique, that has done a lot of efforts in terms of conducting catch-up activities. I think it says Madagascar country team, but today is actually Mozambique. Last month, we featured Madagascar. My apologies for that. So maybe we shall hear now from Dr. Brighton from the Ministry of Health of Mozambique, present for us on the progress that has been made in the country with the 3 rounds of catch-up that have been implemented so far. Thank you very much. Over to you, Brighton.
Hi, Sarah. Good afternoon, everyone. I would like to confirm whether Sarah can hear me. Yes, we can hear. We can hear very well.
Yes, we hear you very well. Thank you very much, Brighton. Sorry about that. Over to you.
Thank you. Well, good afternoon, everyone. I would like to thank you for the opportunity that you're providing to us as a country for us to share our experience, which we've had throughout these 3 rounds of catch-ups for 0-dose children. I would like to thank all the team from the Ministry of Health, our partners who supported us as well, from the planning process to implementation up to this phase where we are now. I am therefore with my colleague Lisa here. She will be wrapping up this presentation here with a component for the communication and generation of demand, but I will start off in a very slow way. I will talk about how the process happened throughout our big catch-up. So I would like to change the slide, please. Well, this is just the content that we prepare to share our experience. Change the slide. By way of introduction, if you don't know Mozambique, Mozambique is a country located in Africa. It shares a border with, as you can see, with Tanzania, we have Malawi, Zambia. In the west, we have Zimbabwe, South Africa, Swaziland, and south, we have South Africa, and last, we have the ocean. According to data from our census, when it comes to our population, in 2024, we have a population of 33.2 million people, and only 1.1 million are under 2-year-old. And 2.2 are children younger than 5 years old, which is the target group for vaccination in our country. And especially because we're talking about the big catch-up, the children who are younger than 5, when we look at the total population, they are 5.2 million people. So this is just to put you in the picture of what we have on top of the complexity of the intervention of big catch-up, but with countries which are densely, when it comes to population, we have further challenges for the process. And we have a growth of population rate estimated in 2.5%. Please move forward. And here's what we want to show with this slide. We want to show how the monitoring system and assessment works in the country. We'll start off with the routing system. And we wanted to say that Mozambique uses in the healthcare centers, which is where the provision of vaccines are done. We have registers, and these are used when we work in mobile in a mobile way, and also the registration of information in those registers. We'll see that you have the daily summary of the content that we've provided, and this information is added by the end of the month and sent to the district. And then at district level, they submit this information on the electronic system, which is based on the DHS2. So we have a cycle of reporting that information. And after it's submitted, the information is available to all levels, so the province, the district, and at national level. We're showing this scheme here just to show a little bit of the complexity that we have. And this happens when we have collated data, because we have this information from the registers, which gets to the electronic system in an aggregated way. And it is in this step that we can view data aggregated, and this is when the central level has access to it. And then from this information, they can carry out the analysis and therefore provide guidance if required. When we started to talk about the catch-up plan for children from 0 to 2 years old, we needed to align the tools considering a system which already works. As a country, we don't have a system that's structured at the community level. Therefore, when it comes to when we find the way we find zero-dose children is via the health facilities. And so this finding of children at primary level is something that required us to design our tools to guarantee that during the implementation, we had the information that could get to each health area. And the exercise starts when we verify if the structure of our registration tools would correspond to what we wanted when it comes to information, so that we could inform our decision making. And it is because of that that I'll move on to the next slide, where we will show one of the tools we use to therefore carry out the mapping of things. But before, as Carolina said, according to the global assessment that's been done, and also with data from DHS2, which is the collated data that the country has access to, the country already showed a growing number of zero-dose children. And only with information from CORPS from 2019 to 2022, we were part of the group of the 10 countries that had the highest number of zero-dose children. So our analysis based on the data we have on the system, on the routing system, showed us where we had those children. And we considered priorities and lack of resources. So what we see on the first map here is the districts which therefore had the highest numbers of zero-dose children. So we start with the yellow ones, so districts that had 5,000 or 10,000 children with 0 doses, and the red ones are the districts which had more than 10,000 kids who were 0 dose. Okay, so if you look at the country level, therefore we have 3 regions, geographically speaking. We have the north, which is the 3 first provinces. They are the ones on the upper north. And then we have the center and the south. As you can see, the north has the biggest number of red ones. And in the north, we have one province which has a population that represents more than 1/3 of the total population of the country. And coincidentally, therefore, these provinces are the ones with the highest number of 0 dose children. So we've been prioritizing things. We've managed to map 74 districts. Therefore, these were amongst these 74 districts, and they were the ones which had more than 5,000 kids with 0 dose. The second map shows something indirect. Here you have the sub-vaccinated children. So here we show coverage for the pentavalent vaccine, and we notice that the countries which have the lowest numbers have a very high problem with that. So let's move to the next slide, please. Due to the result of the analysis from the country, an analysis which were carried out with the help of various different partners we had, there was a real necessity for something. We needed to adjust the strategies that we needed to have to guarantee the identification of these children. So you can see that in my introduction, we have data that we collated together. So we needed to establish something. We needed a strategy to how to find children geographically. So where, in fact, are those children? But we also needed to consider something else. We needed to think of communication to get to these children. It was necessary to funnel down the side, refine the training packages, and also to establish a partnership with different partners who already provide support to those provinces. It was around those discussions when we organized the plan for Mozambique to do a catch-up for 0 dose children. And it was considering this plan that we advocated with Gavi and others. And that's what provided us with the support we needed to move forward. Please move to the next slide. One of the strategies for us as a country to be sure of how we would be able to allocate our teams so that we could do the catch-up had to do with mapping. And as a country, we first started with a pilot project. It was on one district in Nampula province, which therefore is the province that has the biggest population when it comes to the whole country. And this pilot project aimed at verifying whether the tools we have in the healthcare facilities were capable to help us identify where these children are, which communities are they, which location are they in, or where are they when it comes to the concentration points. And we noticed something with the pilot project. The first thing was that in some places, the registers, they were not available anymore. And this was because of extreme events such as rains, cyclones, and therefore with time some tools got lost. But on the other hand, we also had a factor, which was the degradation of these tools. So they were physically ruined throughout the time. So we did have information, but it wouldn't provide us what we wanted to know about the number of children we in fact had and how we could therefore use this information like we want to do based on GHS2. So we adopted a strategy. We decided to do it at community level. Considering efficiency, the use of digital tools, we understood as a country that this would be the best tool, because we would need not only to have information in real time, but also we would be able to get the geographic coordinators and identify these children. But considering the challenges that we have for coverage when it comes to the communication network, considering as well coverage for electricity, and also considering the capability for the use of devices, we adopted something to complement it. We decided to use a manual tool as well to help find the zero-dose children. So we trained everyone in the community. We trained them to use these devices. And we also trained them to carry out the catchment of the geographic coordinators and also the knowledge of the information which are routinely administered. And we need to highlight that the concept we used to get to those zero-dose children was the following concept. It was what's in the guidelines of the WHO. So we wanted to look at those children who got the BCG, who therefore did not get the pentavalent vaccine, but that genuinely the zero-dose children is a child who did not get any vaccines at all. So these were the concepts that we used during our training. And it was because of this information that we created these tools, the manual one and the electronic one. And the mapping was done in 5 days. Throughout the week, we had teams which would monitor the teams during the mapping phase. Move on, please. This is what we're showing something here. This is a tool which was a complement for the manual device that we have. We call this a counting sheet, or ficha de contagem in Portuguese. I apologize because this is done in Portuguese, but on the first line, we have the children who were never vaccinated, so never been immunized at all. And we broke that down when it comes to when they were born. So from 0 to 11 months, from 12 to 23 months, from 24 to 35 months, 36 to 47, 48 to 59. And what does that mean when we think of 0 to 11 months? So it's 2024 now. Therefore, children who are 0 to 11 months are children who were born this year. Children from 12 to 23 were born in 2023. 24 to 35 months are the group of 2022. We have 36 to 47 months old, which is 2020, and 48 to 59, who were born, therefore, in 2019. We were not able to do this in the first round. We acquired experience with this. The first round allowed us to learn things because we understood that this was the only way for us to really monitor whether those children who missed out on the opportunity of getting vaccinated in 2019, 2020, 2021, if we would really be able to help them catch up. So we needed to adjust things on the second and third rounds of vaccination. Please move on. And what did we get with this community mapping? We're showing here in this table the total number of children who were mapped. So this was during the first round. So we had 876,000. 876,841 children. From these, 30% was 0 doses. Therefore, 0 dose children are in both groups, so children who never had been vaccinated, and the ones who only had the BCG, so they didn't get the pentavalent vaccine. When we cross data on the, as you can see on the graph to the right, we can see here what we have in our information system. And we cross that with the mapping content we had. So we see a difference in almost a third when it comes to, it's actually not 1/3, it's actually more than 50% in respect to what we have on CISMA. Initially, when we looked at that, so when we looked at the process for the preparation of the first round, this was something that posed a lot of questions to us, especially about the information we found when mapping. And as I said, we trained the community players. And it was very clear to us that we were not quite sure about whether we had here, in the terms of the number of 0 dose children, would represent what really exists, or whether it's related to the capacity of the community actor to identify the 0 dose children at community level. So this was a question we posed, and this was something that happened from the very beginning. So as soon as we started mapping. But CISMA as well did not allow us to have the information in a way that was disaggregated. It didn't really allow us to get a lot of possibility to cross information between what we have when we map and what we have on the HS2. Whichever way, we did something as a country. We decided we had enough information to move forward. And we had to take responsibility for the children we had on the HS2. And because and during the rounds, we could then see how close we were, or how close the data we mapped was a reality of what we had in the HS2. Next slide. So we, as I said, had to adopt the manual devices or the manual tools as a complement for the countryside, considering the challenges that the community actors would have with electronic devices. And we noticed something. The use of electronic devices is still a challenge. this is in spite of the quality of information that this tool allowed us to have, and also how it allowed us to plan. But overall, we've seen something. Only 2.2% of the volume of children mapped that we had with the electronic devices. So what I mean is the majority of provinces, the community actors ended up choosing to use the manual devices, which would be the manual mapping sheet. Move on. Now I'm going to talk about results. I want to start off by showing the blue graph. So the blue graph shows the number of children who were vaccinated in each one of the rounds. So from the first one, and then the second and the third. And out of these, how many of them were children who were zero dose? There's something I would like to clarify here. Differently from the mapping we used with the community actors, during vaccinations, the health technicians duly trained who were part of the teams, they were people who used the register, and the register will get the age for the children, the place where they live, the contact details for the mother. But more than that, we use the register with separations. And then these divisions in the books, they bring the different communities and each health area. And what do I mean by that? What I mean is that if, let's say, nowadays, I have a child coming for a vaccine today. I registered them, and first thing I ask is, where does this child live? And then based on the community, the child is registered, and this information helps the movable processes, because we do this in communities and we have different concentration points. So because this book separates the communities, it helps us to identify children, and this helped in the next rounds as well. So when I choose a team for a community, I considered the register used in that community. You can see that in the first round, we had 251,000 children who were zero dose. And then they were vaccinated children. And the mapping, if you remember, showed us that we had found about 262,000 children. So that means with the first round only, if we based on mapping, we would be more than 80% outreach for zero dose children. But as I said, as a country, we decided that we had a need, considering what the information system allowed us to see. And when we finished the first round, we had a group of children who got all the vaccines. And these, they were not eligible for the big catch-up anymore. And the big catch-up looks at children who were 24 to 59 months old. But clearly, we consider things as a country. So we wanted to potentialize our interventions. We wanted to also get back to the routine. So we integrated as well the peri group from 0 to 23 months old. As I said, at the end of the first round, we needed to make adjustments. And this was so that we could estimate the group which we would predict for the second round. And clearly for the second round, we really had to subtract those children who we considered in the first round as children who were fully vaccinated, so they were not eligible anymore. And with this information, we were able to estimate things. So we could estimate the group for the second round. And what we see here is that from the first to second round, the number of zero-dose children got lower, which in a way gave us a clear picture that the first round was something that worked. Because with time, you can see that the numbers got reduced from round to round. So this scenario of a reduction of zero-dose children, even though we didn't have a clear catch up for all the children who really were included in our information system. We saw a reduction from round to round. And so that means from the first to the second round, there was an effort, and this effort had a result. With time as a country, we managed to get to children. This happened gradually, but we got to the zero-dose children. And we'll move on to the next slide now to talk about what the global reach when we get to the end of the third round. But before, I want to show you the provinces. As I said, Nampula, which is the third one that I'm showing here, it shows the province with the highest number of zero-dose children. So clearly it has the largest target group for vaccination. And then we have Zambezia, second place. So these have the biggest number of children. And if you think strategically as a country in these two provinces, the criteria for prioritizing things had to be pondered. So we needed to include all districts for both provinces because they were priority for the country. But I want to show something overall about us as a country. When it comes to children from the first to the third round, we have a trend to have a growing number of less zero-dose children. Please, next slide. So we have a table here to show the number of children who were vaccinated. This is on the second column. On the third one, we have the target group for CISMA or the DHIS2. And this is what it represents in terms of coverage. So we got to the third round for the big catch-up, and we got to 69% of children who were zero-dose. It's clear that there are provinces who face higher challenges than others. But we were very happy as a country. And we also understand that this process established a culture for the routine. Furthermore, you understand that there was a system that was established during the 3 rounds, which is something that will help us strengthen the routine. And now that we have the registers for these children, and these children are registered per community, which is still possible because it guarantees that these children will be identified. But not only the children, We also managed to strengthen our visits in these communities where we have a higher number of zero-dose children. Next slide, please. Right, so this, I just wanted to show the rounds. On the first round, as you can see, we had a complex situation. We didn't manage to separate children based on date of birth. We had 2 age groups, which was from 0 to 23 and then 24 to 59 months. And this is what we show here. But in general, what we want to show with this graph is that the cohort from 2022 and 2023 represents the target group for the routine, so the routine vaccination. They represent the period. And what I want to say is that the big catch-up not only allowed us to recover the children who were older than 2 years old, we also managed to use the big catch-up soon after the first round to guarantee that we had gains for routine vaccination. Next one, please. And therefore, clearly here, we show the data for the second and third rounds. And all in all, you can see that the cohorts which were closest in 2021 and 2022 are the ones which have the highest number of zero-dose children. But all in all, the most important thing to show here is that if you consider the various cohorts, there was an improvement. And this is an improvement that happened between rounds 2 and 3. So this is something that shows us an important thing. It reinforces what I said before about the different rounds. Next slide, please. So yeah, we have something that we show here. And we're considering the global contribution for the big catch-up for the period. So for the target group from 0 to 21 months old, so for the first round, we had a contribution of, considering all the children who were vaccinated, 48% were the period. And then for the second round, half, and which was similar for the third round. So all in all, this is just to show that the integration and the planning of the big catch-up, the integration of routine vaccination was something important to us as a country, and we understand that it provided a gain for us. We had positives with this strategy. Next slide. Agora os desafios. I believe that Mozambique is not different from other countries. We have children with they have the children with zero dose as well. We had several challenges. They were different from others, obviously, but the first one is related to mapping, to community mapping, as we showed. And also in the first round, we got the guidelines for monitoring and assessment. And from the outset of the process of implementing the big catch-up for the first round, it was something that did not allow us to strengthen our monitoring structure. But it's clear that from the second and third round, we managed to therefore adjust things considering the guidance that we received. Mozambique faces challenges that have to do with the access to the internet. There are places that have no coverage, but then somehow during the implementation, the reporting of this information so that it could be used in the electronic system would take some time because of the limitations. So normally teams collate data and then they try to get access to the internet to send things. So during the process, we didn't always have the full data, but by the end of it, we really had a full level of the number of data. So these are challenges, but when it comes to a process that's for a long term, it has some impact because for every balance, we need to consider decisions based on the data we have. We face challenges about some concentration points in their axis as well. So the image we have here shows a little bit of what the challenge is all about. So as you can see, the car was driving the vaccination team. They had to park a bit further out, and then the teams had to continue walking. Some challenges are more complicated than this, but this is a bit of what we would like to share. But in spite of the challenges we have, we believe as a country that we were providing gains to our population. Next. So what are the lessons learned? The first one has to do with the definition of the target group. So as I said, we did some mapping, but we also had data from the DHSI2. And what we noticed as well is that the definition of the target group in the second and third rounds were a bit more complex because when we were midway through the rounds, we had children who not only got all vaccines, but we had other children as well in terms of their age. So children who were not eligible anymore. And in the monitoring system, we did not managed to get that information. So how many of them were vaccinated in the first round? How many of them are older than 5 years old? And therefore, how many are not a part of the second round? And that's it. So we understood that from this lesson learned, we need to convert the monitoring system into something electronic. So we need to get the analysis to national level. So these are things that we understand that we need to work on as a country as next steps. And of course, we have other challenges as well, challenges that have to do with the implementation of the first round. So when we planned the first round, we didn't have a clear idea of how dispersed the zero-dose children were. I will explain a little bit about that to you. The aggregated system allows us to say that in if this health area X has a number of children, but these children are not in the same community. They're dispersed. So this dispersion, therefore, results in us needing more resources. And when I say resources, I mean human resources, money, transportation, because people need to travel to those places. And we didn't want to leave anyone behind. So these lessons allowed us to improve. We became better at planning the second and third round. We needed to therefore adjust a daily target for every team to guarantee that every team would make sure that they would therefore be able to get to the more distant places. So these are adjustments that we also needed to look at. This is a lesson learned. we would like to share this experience with the colleagues as well. Please move on to the next slide. Considering our next steps, we are still undergoing a process of verification. Less than 2 weeks ago, we finished the 3rd round for the big catch-up, and there's still an ongoing process of verifying sources, of seeing how many vaccines we're using, of crossing data as well. But we also have a process, and it's a process of analyzing the geographic coordinates, just so we can guarantee that we're monitoring the zero-dose children. And to allow that using this geospatial information, we can make better plans for the mobile squads. We also have a need to guarantee so that we can establish our community bases. We are trying to consider using Upscale, which is a tool that's used by the community actors. And we believe that when we establish this capacity at community level, we will be able to have the visibility of the zero-dose children based on the places where these children live. So these are aspects which we're discussing as a country. And we believe that the willpower that we have to make things better and better and better will allow us to achieve better results. Next slide. When it comes to final considerations, before I let my colleague Elisa speak, I would like to say that the data we have here showed us very clearly the number of zero-dose children was very, very much lower than the expectations for the DSH2, and also the global estimative are showing. But also we want to say that us as a group, as a country, during these 3 rounds, have managed to reach about 69% of children, which is very good to us. It's true that we still have work to be done to improve things. We want to get to 100% of zero-dose children, so we have an additional work to be done. And clearly, as a country, we notice that there's a need for us to carry out a study, so to map things at community level, so that we can really see the real impact of the 3 rounds for the big catch-up. So these are aspects that we would like to consider to wrap things up. And I believe that the partners we've been following will be following us as a country. They will look at these aspects that we're showing here. I will very quickly give the floor to my colleague Elisa to wrap it up, and she will talk about communication. Thank you.
Dr. Brighton.
Thank you, Dr. Brighton. And once more.
Yeah, thank you very much, Dr. Brighton. Just in the interest of time, hopefully Dr. Elisa will move pretty quickly, maybe just 5 minutes, so that we can allow time for question and answers. But thank you very much, so far, for the presentation. Over to you, Dr. Elisa, just 5 minutes.
Yes, thank you. Thank you so very much. Thank you, first of all, for the opportunity that we're having to share what is our experience here when it comes to the big catch-up. When it comes to demand, to creating demand, this is our experience with the 3 rounds. Before we started the interventions, we had a study, research, and it was a quantitative research, a survey. And we wanted to know what's behind or the barriers that we have for children who are zero dose. So this research consisted in something we did in 4 provinces, and you can see to the right at the top, we have a map of Mozambique, and this research was done in 4 provinces. It was 16 districts and 31 administrative areas. So we selected the ones which had the highest number of zero-dose children. And we had carers who were 16 years old or older, and those were people who had the vaccination card for children. We had a total of 7,200 people who were interviewed. Therefore, this research had some results. As you can see here, we worked with quantitative levels at household level, and we saw things like the geographic determinants. We realized that when people have less access to education, so people who come from a low education background and young parents as well, we have a lower possibility of vaccination. And also considering what they think or they feel. So the population thinks that vaccine is safe, the more they're likely to get vaccinated. I'm thinking of social processes as well. Here we have the perception that the neighbors have when it comes to the influence. So neighbors and others who influence them increases the possibility of vaccination. So if my neighbor has a positive view on vaccines, it can influence other neighbors. And also in households where fathers are less dedicated to children's health, we have children who are less likely to be totally vaccinated. And we have as well gender. In families where women contribute to the family income, so families where women who have income, when they are the breadwinner, we have more likelihood of these children being completely vaccinated. But those situations where the decision power rests with the man, the number is reduced. And we also have practical issues as well. Carers of children who got all vaccines in one appointment. So a mom who takes her child for a vaccination, let's say it's a 4-month-old, she knows there will be 5 vaccines at the same time. If she goes to the health facility and has all vaccines available, she is more likely to have a child who will come back for vaccination. So this is about the study. Yeah. But we can move to the next slide since I only have 5 minutes. I've made a summary of the study here. So this is a quantitative survey. But along with that, Mozambique also does inquiries that are fast. So they go to the community. And these show as well some of the contribution when it comes to the perception of the mothers. So when it comes to the inquiry here, we have the percentage of carers of people who went to the health facility. So how many of the mothers or carers who were provided with information about the vaccines that their children were getting? So as you can see here, when we got the green bit, 60%, 62.7% carers were provided with information to say this child is getting this vaccine. But we still have a concern because 37% of mothers did not have information on what vaccine was being administered. considering adverse events as well. So the more information people have about adverse effects, if this mom is well guided, she's more likely to take the child to be vaccinated. Therefore, I'm bringing this summary to say that in this survey, in this community survey, is something that shows us what the population is saying. So how we can improve the vaccination activities. For example, they say that parents have the information on how to improve vaccines. We have to wait for less long, so not waiting for that long at health facilities. Having vaccines at the health facilities, improve interpersonal communication, and increasing the number of healthcare professionals. Next one. Next slide. So here we have the general objective for the big catch-up when it comes to communication. The main objective is guarantee that the population is provided with adequate information. And so here we have approaches. First, we have advocacy, then we have social mobilization, and then we have the materials used during the big catch-up. When it comes to advocacy, we've been doing meetings with the governments and advocates from bottom to top. We have meetings with community leaders to provide basic information to how they can instruct the population. We also have advocacy meeting religious leaders, because once they have this information, they will pass that information on in mosques, in churches. So this is our foundation. And also gatherings of advocacies with local musicians, with journalists, because a well-informed journalist will be the biggest ally to promote the essential message. And when it comes to social mobilization, this is how it works. We use community actors, and we have two components. We have pre-campaign and during the campaign. So the communication starts before and continues during the round. So we need to inform people. So during the round, we share information, for example, on radios, on the radio. We have 11 or 12 languages in Mozambique. So we have broadcasting on the radio so that the population will know in their language. And we also use influencers, so digital influencers, to talk about things. The materials we used, so it was broadcasting on radio, and we also had mobilizers. So we provided all information, we provided things that could be shared, that they could read in religious ceremonies. And also,
I'm so sorry to
and
interrupt.
also we had different things as well for the routine vaccination.
Let's wrap it up in just 1 minute.
And then I'm bringing what is the focus of the materials and the relevance of this information. So what we have in this component, in this strategy, what was the key information? First of all, it's important to inform about the dates. So when is the first, the second, and third big catch-up? We need the dates and the place for the immunization. That's important. We need to explain the benefits of the vaccines. We need to inform carers about the importance of following the schedule. So the catch-up is for recovering children who are even older than 5, but we have routine vaccination. So to create sustainability so that we don't need to have a fourth big catch-up. We needed to inform people to prevent that, and also to put parents at ease when it comes to the safety and the efficacy of the vaccines, to explain the adverse effects, which are normal to vaccines, and this needs to be done in a calm way, without creating any kind of chip on parents' shoulders. Next slide. I think I'm running out of time here. Next slide. Yeah, so this is just a graph about independent monitoring from door to door. We did this in the third round, and this was more specific in Cabo Delgado. We know that they had the big catch-up, and we had integration of other vaccines as well. This was the one we had for measles. But here we have this slides, and what I wanted to show here is that in this result, we're saying that we didn't have any refusal. We had 0 refusal. So all mothers and fathers agreed to take their children to get vaccinated. There will be 1 or 2 children who are not vaccinated, but if that happened, it's because that child's mother was busy. So what we have to say here about the experience we have and how communication works. So I've run out of my 5 minutes here. Thank you so very much for the time that was dedicated to me to speak for 5 minutes. Thank you.
Great. Thank you very much, Team Mozambique. I think we can all acknowledge that you've really done a lot. Very encouraging results from the country team. Very encouraging to see that you've successfully conducted 3 rounds from which you've been learning and adjusting after every round. Really appreciate that last presentation on being able to identify what are some of the drivers for uptake. And notably, refusals are not part of it. So it looks like we probably need to hear more about whether it's an issue of access, vaccine availability. But I think as we now start to look at the question and answers, given that we're out of time, I'm going to ask partners in country, WHO, UNICEF, and Gavi, if you can just support with responding to the questions. I was going to allow for you to be able to come in and weigh in, but given that we just have 7 minutes remaining for this webinar series, maybe we can just dive into some critical questions that have come up in the chat. I think one of the questions here is the definition of 0 dose. So what definition has the team been working on in terms of 0 dose children? I don't know who would like to take that. I don't know if it's Brighton, Carlos, Mario, Ming, or Dr. Eliza. Anyone who'd like to take that on the definition of 0 dose in the...
This is Brighton here. I will speak. The definition that we used for 0 dose was as follows. We use the one shared by Gavi. So what we do is we look at children who had never been vaccinated. But as our monitoring system has its limitations when it comes to having this information regularly, it was difficult to map. So we decided to look at the indicator we had on CISMA, which was to see children who got the BCG, but who did not get the pentavalent one. So did not get the first dose of that one. And so we found the difference was that in a period of, let's say, the cohort of 2020, how many of them had the BCG? And then we tried to see how many of them had the first dose of the pentavalent. So we found a difference. So the difference between BCG and pentavalent is what provides us, therefore, with the estimate of children who were 0 dose in our country. Thank you.
Great, thank you very much. I think that's very helpful. I think it's in alignment with the fact that the 0 dose children are defined as the ones who have not received Penta 1, with consideration for the children who receive this BCG. But we do have colleagues also from HQ here on the call with us who can also chip in. The other question also that comes up is on the tally sheet that you projected, Brighton. So it's good to see that you've broken it down by the back cohorts. but is there a place for indicating which vaccine was given during that time? And are these tally sheets the same ones used in the health facilities during the periods? Are they the same to used during the outreaches, during the facility visits? Mhm.
Thank you, Sarah. This tally sheet that's been shown here is something that we needed to create in the context of Big Catch-up. Our register routine tool is not broken down like this. So it's just a register, and we've got name, age, and then the vaccines that the child had, or the ones that they have to have. By breaking it down this way, during the Big Catch-up, we managed to see things immediately. So the one administering the vaccine would get the child, and they would be able to ask the right questions to know if this child is 0 dose or under vaccinated. And then if the child is 0 dose, he puts a little circle, and then he just counts the number of circles, and that allows us to know how many 0 dose children he vaccinated on that day. So this was a complementary tool which really helped us during the implementation of the Big Catch-up.
Okay.
Thank you.
Good. Thank you so much. I think that's very much appreciated that it did not, it was just complementary to the existing tools that and registers that are used to register vaccinations for children. Now, the other question that comes up is on slide 32. You show that about half the children that were vaccinated were 0 to 23 months. And so what happens for the children that are above that? Has there been any specific communication, any linkages that have been made to encourage catch-up for children above the 23 months of age, the 23 to 59 months of age? Slide 32.
Thank you. I was going to pose that question to my colleague Elisa, and then I could add. It has to do with communication strategy, but actually the strategy was not different. But I would like to allow Elisa to have the floor to answer the question. Yes, thank you. The communication strategy we used was the one I've just talked about. We had meetings with community leaders. We know that routine vaccination has as a target group children under 2. So we intensified the meetings, including lectures. And then if it's something, if you look at the very outset, we have the mobilizers who go around on bikes, and they would go around calling every children who are younger than 5 to go to the health facilities. So this is where the technician would do the screening. So they use megaphones, got the children to go to the health facilities, and this is when the technician would see, and then this is how we got to all those children.
Great, thank you very much. And maybe this question goes to all the partners in country. Is there any specific format that's being planned for in terms of conducting, or that's being done already to conduct the review meetings? After you've done the peries, the assumption is that you meet together as a team with the Ministry of Health to review performance. I don't know if maybe this time we can hear from other people within the country team. Anybody? Carlos?
Yeah, yes, so yeah, coming just to quick answer on that question. Yeah, actually, we are concerned about the evaluation, conduct evaluation, and it's under discussion how we're going to implement that activity. Yeah, but just to emphasize that the tracking of 0 dose is not closed. Is not how can I say, is ongoing process, because every day we'll find children that they are missing or are not reached by immunization service. So it's ongoing process, but nevertheless, we'll discuss how the best approach to conduct the evaluation of this process based on all constraints that were presented by Dr. Brighton here.
Great, thank you very much, Carlos. And indeed, we've noted that with every catch-up activity you've conducted, you're able to catch up on zero dose, but also it looks like you're identifying new zero dose children, which is a bit encouraging to see the progress that you've made despite the significant challenges. I don't know if anyone on the team would like to comment about some of the hard-to-reach communities in Mozambique, especially, for example, the conflict-affected areas, and what strategies are being used to reach the zero-dose children in those areas. Anyone from the country team, from the partners? Anyone? Or we can defer to Brighton if there's nobody to reflect on that. Maybe Brighton, we defer to you then.
Thank you so much, Sarah. Actually, I was waiting for my colleague Arlindo Banzi, who's here in the room as well, who could help us answer that question. Because he's a key player in this process. He works with service provision. So I didn't want to deprive him of an opportunity to express himself. So I will insist a little bit more for him to answer the question. And then if I can't answer, I will then, if he can't answer, I'll do it then. Dr. Banzi?
Thank you.
I will answer. In fact, we have an ongoing challenge, not only for big catch-up, but also for routine vaccination. And there are places, because of the lack of safety, as you said, we had a mobilization of the population. This was noted in almost every district, which are neighbors of Cabo Delgado, which is a critical province. So a lot of the population has moved to Nampula. And in these places, therefore, the target group was higher. So when we calculate routine coverage, we can see that the number of children who were vaccinated in the last 12 months got a lot higher. But during the implementation, we as a country first always consider safety as an utmost concern. And there are some situations where, in spite of the various strategies, we cannot get to those places. So there were places where it was impossible for us to get to. But there are places as well where, if we have support from law enforcement, from influencers, we managed to get to, we managed to visit. But in places where, really due to safety concerns, we couldn't go to, it was not possible to work. And we could not provide our services. We've been strengthening something in these countries, though. We've been using the mobile squads for routine vaccination. And Cabo Delgado, as a province, because of this particularity, has been receiving the support, especially for transportation. We've rented cars recently to also help this transport component, because the population is dispersed due to conflict.
Excellent. Thank you very much. I think this has been very helpful, and definitely we acknowledge some of the challenges you're still facing as a country team. And the reason we came together this way is to learn from your experience, given how much work and effort has been put in place. So as usual, we remain available to support the country team, especially after learning from the challenges you've had. I encourage everybody to please share your thoughts and feedback directly to either myself or Elias Forbin or Alex, who's also on this call, as well as there's going to be a survey that's going to be shared on the chat right now so that you can also give us your thoughts and feedback more broadly on big catch-up efforts that are ongoing in our region, especially having seen the progress that Mozambique has made so far. Special thanks to Brighton, Dr. Eliza, and others, as well as Carlos and others on the team that are in the country that have really put together an excellent presentation. Thanks to Carolina. Thanks also to Alex for facilitating this session for us. We look forward to learning more from other countries. And I think for now, we shall wrap it up because I know most people right now it's time to go home. So it's been an excellent session. I just want to wish everybody a good evening and until we meet again. Thank you so much.
Thank you.
Bye-bye, everybody.
Thank you, everyone. Bye.
Thank you so much, and I'll see you soon.